I'm honored to serve as your moderator for today's globally collaborative session. Before we begin our session, I would like all the participants to kindly keep your microphones muted throughout the session. And for questions, please use the Q&A or chat options. And moreover that, we will be taking all of your questions during the dedicated Q&A session later, inshallah. So today's webinar brings together some of the most respected and influential names in modern optometry and vision science. We aim to create a meaningful learning experience on some of the most impactful topics in global eye care. To officially open today's event, I would like to introduce our esteemed host, Dr. Shahadat Hussain Delowar, who has done OD BS Optometry, MSc Optometry, Mphil, and who is the Global Eye Healthcare Consultant, Vision Awareness Educator, and CEO of Optometrist TV and Eye Doctor TV and Abira Ophthalmic. So, Dr. So much for leading this initiative. Okay, so now we will be moving on with our first guest speaker. Our first guest speaker is Dr. Maryam Jabbar. She has done Doctor of Optometry and MPhil and serving as a lecturer at the University of Faisalabad, Pakistan. She will be presenting on a very important topic, which is myopia in schools, public versus private educational environments. So, Dr. Mariam, we welcome you and looking forward to your insights. I'll be playing her pre-recorded session for this webinar. So,
hello everyone, Assalamu alaikum. Here's me, Maryam Jabbar, currently working as lecturer of Optometry Department, University of Faisalabad. Recently joined as Media Secretary, Pakistan Optometry Society. Pakistan Optometry Society is an organization that has been working for the advancement of optometry in Pakistan for a long time. I would like to extend my appreciation to Institute of Community Ophthalmology, Bangladesh to organize this event. Let's start today's presentation. Let me share my screen. Bismillahirrahmanirrahim. Topic of presentation is environmental educational environment and myopia, a comparative study on prevalence of myopia in public and private sectors. Basically, this is a snapshot of our recently published article. Let's start from the introduction. According to World Health Organization report on VN, myopia is becoming an increasing global health concern and the leading cause of avoidable blindness worldwide. There's a graphical representation that shows that half of the world population will be myopic by 2050, and this is alarming condition. Let's start from the rationale and objective related to this study, current study that we have proceeding to present over here today. Difference between the public and private schools of Faisalabad, Pakistan, and impact of digital learning, lightning, and outdoor activities, and need to identify the school-based myopia prevention strategies. Furthermore, the objective of the study was to compare the educational environment in public and private schools and to determine the prevalence of myopia among students of Faisalabad. It's the methodology section. This cross-sectional study was conducted in Faisalabad during the tenure of August to December 2024. A sample size of 621 students, age range from 8 to 15 years, and data was collected through stratified sampling technique. We classified school into two strata, public and the private sectors. Furthermore, the data was collected as per the guideline of Declaration of Health Concern, as the human subjects are included in the study. Furthermore, to conduct this study, the ethical approval was taken from the Ethical Institutional Review Committee of the University of Faisalabad on 5th June 2024 to conduct this study. And here's the pictorial proceeding of data collection protocol, starting from the taking consent form, and then we proceed with the real equity testing that proceed with the log bar chart, and hereafter we proceed with the subjective and objective reflection. Furthermore, here's the result section. According to these study findings, there was a total 621 students and mean age of 13 years with 1.89 standard deviation. Furthermore, is the graphical representation of the gender distribution. 289 were the male and 332 were the female. And as we initially discussed, we divided school sectors into two strata. That's proceeding with the public and the private. In the private sectors, 234 students were included in the study, and for the public sectors, it's proceed with the 387. The total of 621 students included in this study. Furthermore, in context of the refractive status, the total of 210 individuals were diagnosed with the myopia, whereas 411 were the non-myopic. That's indicate the 33.8% myopia prevalence as per these study findings. And furthermore, is the graphical representation of frequency of degree of myopia that's classified as mild, moderate, and severe. Mild degree proceeding up to the 3 diopter, moderate proceeding up to the 3 to 6 diopter, and high myopia proceed with the above 6 diopter. And furthermore, in this study, findings conclude that there were 119 individuals proceeding with the mild degree of myopia as compared to the moderate 70 proceedings, and high degree of myopia constituted with the 21 individuals. According to this study, in these schools, the high prevalence of mild degree of myopia as compared to moderate and severe. Furthermore, here is the educational environment at the school comparison. That's basically about the classroom lighting, outdoor activities, and the use of digital devices such as computers, laptops, and the mobile screens. Furthermore, here's the tabular formation. Let's proceed with the comparison of public and private school lighting, classroom lighting. That's further proceeding with the artificial light and the natural light. In public schools, they are more dependent on the adequate natural lighting as compared to the artificial lighting in comparison with the private schools. Here is the further proceeding with the usage of digital devices. That's we further proceed with the less than 2 hours and the more than 2 hours. In proceeding with the public school, there is no, they don't rely on the digital devices. So less than 2 hours proceed with the 314 individuals, and more than 2 hours with the proceeding with the 73 individuals that basically proceed with the high grade that's proceeding with the computer lab proceedings. Furthermore, in the private sectors, there were total, out of the total individuals, 65 were those who have less than 2 hours, but majorly proceeding with more than 2 hours. That's one, basically 169 individuals. And furthermore, is the frequency distribution of outdoor physical activities in public and the private. In public school, there is more outdoor activities as compared to the private one because of the more spacious proceeding for the outdoor physical activities. And here's the frequency of myopic individuals in the public and the private. Here's the graphical representation that show the 101 were myopic in public sector out of as compared to the non-myopic. Non-myopic were 286, while in private sectors 125 were non-myopic and 109 were the myopic in private sectors. So in comparison of myopic and non-myopic in public and the private sectors, private has more prevalence as compared to the public sector. And here's a discussion portion. We simply we conclude this study. In private sectors, there is more use of the digital devices, and they dependent on artificial lighting as compared to the natural, and few outdoor activities. But in comparison with the public school classroom proceeding with more natural lighting as compared to the artificial. Furthermore, more outdoor activity proceeding and less reliability, less proceeding on digital devices. Furthermore, myopia is linked to the less outdoor activities and the more near outdoor, more near work. And the previous study that conclude the same. The daylight rich classroom reduce the myopia risk as compared to the artificial lighting. And furthermore, here is a study that's proceeding with the screen time and the near work that accelerate the myopia. And current study as well, current study also conclude thus the post sectors has more screen time for the educational purpose as well as for the non-academic proceedings. Furthermore, here's the conclusion. Myopia was what was found to be more strongly associated with the private school environment because of less outdoor activities, greater use of the digital devices, and more artificial lighting as compared to the public sectors. Here is the few tips for the proceeding with the enhancing eye health. Including the reduced screen time, increasing the outdoor activities, maximize the daylight exposure, and improve classroom lighting conditions. These are the recommendations, and these are the strategies that can help to develop to slow the development and progression of myopia in school-aged children. Here is the full length paper. If you want to read, go ahead and scan, and you can find out the full length paper. That's all from my side. Thank you so much for listening. Go ahead for any.
Dr. Iqra Salam, please.
Yeah, okay. So now moving on to our next speaker. It is my privilege to introduce our next chief guest speaker, a world-renowned vision scientist, researcher, and respected academic figure, Professor Dr. Mark Bullimore, who has done FCOptom, MCOptom, PhD, Fellow American Academy of Optometry, and professor at the University of Hossen, USA. Today, he will be discussing orthokeratology, an essential and evolving pillar of modern myopia management. Professor, we are deeply honored to have you with us, so the stage is yours. Thank you. Professor, can you hear us?
I can hear you, sorry. Thank you for that kind introduction. I just need to attend to something. I'll be back in 10 seconds. You can see my screen, I hope. So I'm going to be focusing on orthokeratology today, but also giving a slightly broader perspective. Before I begin, I'm affiliated with the University of Houston, but I make my living working with companies large and small, and of course many of the companies you can see there have an interest in myopia. You see this QR code on the left. It's also on my background. If you scan that code, it'll take you to my website, and it'll give you a list of recommended reading on myopia management. And some of the papers I'm going to talk about today are listed on there. Most of these papers are also open access. So why myopia? Why now? Because when I was studying optometry, we regarded myopia as a somewhat benign refractive error that we would treat with contact lenses and glasses, and perhaps more recently with laser refractive surgery. But things have changed for a number of reasons. We've heard about the increase in prevalence, and Maryam presented some very nice data in her presentation. We also have a better understanding of its importance and the role that myopia plays in uncorrected visual impairment. But finally, we now have the ability to do something about it. So we have interventions that can delay the onset of myopia and also slow its progression. Now, when it comes to looking at evidence, we like to see the highest quality of evidence. We live in an evidence-based world, and this is the evidence-based pyramid. And you can see at the top, randomized controlled trials. Now, there is actually even a higher level of evidence, which are meta-analyses, where multiple clinical trials are analyzed together. And of course, at the bottom, you've got expert opinions, which is a very low form of evidence. And then, of course, even below that, you've got social media and politicians that unfortunately we get bombarded by. So in terms of different interventions, we've just published this International Myopia Institute report on interventions for controlling myopia onset and progression. And the figure on the right is the sort of the big take-home message, where we compare the efficacy of a range of different interventions, be them spectacles, lenses, drugs, and red light therapy. And we also compare the efficacy within those categories. And I'll drill down a little bit on some of these, but I do recommend you take a look at that paper. So I showed you some graphs there, but let's get back to think about how we describe the efficacy of a myopia control intervention. Obviously, on the left, we can measure axial length, we can measure refractive error, and we would hope that they would be well correlated, but both are influenced by age and race of the patient. For axial length, we like to see optical biometry being used. We no longer use ultrasound in clinical trials. And for refractive error, the best measure we have is cycloplegic autorefraction. Now, in terms of defining efficacy using those values, we have a number of things that we can do, including sort of the proportion of children that progress by a certain amount, the percentage slowing. But the one at the top is what we want to really focus on: absolute changes. And the cumulative absolute reduction in axial elongation, or indeed refractive error, is really what we focus on. So this is a graph that Brennan and a few of his colleagues published, including me. And on the right, you can see the reduction in axial elongation. That's the efficacy of a myopia control intervention for a range of studies. And one thing you can see is that the lines aren't straight. You get a greater slowing or reduction in axial elongation in the first year than you do in subsequent years. And you'll see that on all the graphs I present later. So how do we get those graphs? So we start off with the figures that we see in every paper, showing the myopia progression at the top and the axial elongation at the bottom in both the treated and the controlled subjects. So we take the difference in axial elongation, say at 12 months and 24 months, and then we plot that on the graph. So that's how we get those those graphs of efficacy. And you can see that the lines continue to go up. We can add some additional interventions here. These are all different spectacle lenses. And you can see where there's multiple years of data, the slope is flatter in the second and third year. That is to say, the efficacy is greatest in the first year. Now, one of the advantages of using CARE, or the cumulative reduction in axial elongation, is that it's relatively unaffected by age. So I've given you two data sets here. The one on the left is from the LAMP study, a study of 3 different concentrations of atropine. And you can see, if you draw a line through the controls at the top in red, and just as an example, the highest concentration, the green dots at the bottom, 0.05% atropine, you see that the lines are parallel. On the right, there's a randomized clinical trial of red light therapy, and the authors have done the same thing here. They've plotted axial length changes as a function of age, and you can see that for both the red light and the single vision spectacle control condition, the lines are parallel. Now, the problem with percentages is that when you look at percentages, they are very, very dependent on age. So in older children, you can get complete sort of arrest of myopia progression and axial elongation. And that gives you percentages, of course, that are greater than 100%. Down at the bottom, you can see, on the left, you can see that the percentages are much, much lower. So percentages can be very misleading. So that's why in this paper, we focus on the absolute changes in axial elongation. And in the tables, we also give the values for myopia progression. So we have a number of myopia control options. These are the major ones. What you have access to depends on your scope of practice. And some of you can prescribe drugs, some of you can't. And also the availability of these products within your region or within your country. So let me just start talking first of all about overnight orthokeratology. So going back in time, and it seems a long time ago, but it was only about 13 years ago, Pauline Cho and colleague published the first study that really demonstrated the effect of slowing of axial elongation with overnight orthokeratology. And over a 2-year period, the children wearing overnight ortho-K, they elongated by about 1/4 millimeter less than the spectacle lens wearers. And again, if you look at the graphs on the left, you can see that most of the benefit actually occurs in the first 6 months. Now, the authors then went and did a randomized clinical trial, and they again found about 1/4 millimeter slowing of axial elongation over 2 years. And these results have really been borne out by other studies. One of the things that's remarkable that you can see on this graph is that when you look at the 2-year slowing of axial elongation with overnight orthokeratology, it's remarkably consistent across different studies in different countries using different lenses. And we see that, again, this is a figure on the right taken from our IMI review paper, and you can see generally the results are remarkably consistent, and much more so than other interventions. Now, some of the lines at the bottom where you've got less efficacy are actually most of them are in less myopic eyes. And this is demonstrated quite clearly in this study. This was a retrospective study of myopic anisometropes. So you've got children with relatively high myopia in one eye and lower myopia in the other. And you can see over a year, those wearing single vision glasses, it doesn't matter which eye you're looking at, the elongation's a little over a 1/3 of a millimeter, and it's the same in both eyes. In the children that were wearing HAL lenses, that's Essilor's Stellus lenses, there's a reduction in elongation in both eyes. Interestingly, on the right, though, with orthokeratology, you see a robust slowing of axial elongation in the more myopic eye and less effect in the less myopic eye. And we know from a number of studies that you need a reasonable amount of myopia in order to get a treatment effect or an optimal treatment effect. So just to compare that with other kinds of devices, let's just talk briefly about soft lenses. These are data from the MySight clinical trial, which was published about 6 years ago. You can see over 3 years, you've got a slowing of about 2/3 of a diopter and a slowing of almost 0.3 millimeters of axial elongation. And what you can see in both the treated and the control populations, you see a correlation between axial elongation and myopia progression. More recently, a large randomized clinical trial of almost 300 children, they randomly assigned children to either wear a high-ad center distance multifocal contact lens, a medium ad, or single vision. And one of the remarkable things about this study is that 98% of the children completed the 3-year study. What you can see is both for axial length and for myopia progression, there is a slowing of growth or slowing of progression with the high ad. So you've got almost a half a diopter slowing and about 1/4 millimeter slowing over 3 years. The medium ad was less effective and not significantly different. So if you're going to use a center distance multifocal, then obviously going for the high ad. And again, these are data from both those two studies. You can see the red and the orange lines at the top are from the two studies I presented, and the blue line at the bottom is for the medium power ad. Those are the only studies with 3 years of data in a randomized clinical trial. But you can see a range of efficacy. So again, I encourage you to go back and take a look at these data here. If you were to sort of cherry pick and look at the best cases from each category, you can see that down the bottom, 0.01% atropine and progressive addition lens spectacles are generally not very effective. But then in the middle, you've got a range of options, including ortho-K and dual focus contact lenses that are very effective. The most effective is red light therapy, but in its current incarnation, I regard it as unsafe and don't recommend using it. In terms of which treatments are best, I get often asked this. It's like asking a mother, though, which of her children she loves the best. My answer is always the same, regardless of who's asking me the question. It's the one that the child will use. And of course, there's a bunch of considerations that we talk about in this paper, including safety, comfort, vision, lifestyle, but really compliance is the most important aspect. So the most important aspect of myopia control is choosing something that the child will use. So I leave you with this fairly busy slide here. This is what I call the continuum of myopia care. And I've mainly sort of talked about number 6 in the middle of there, but we also need to pay attention to myopia in a very young child. We need to pay attention to predicting who's likely to develop myopia and intervening. And later on, we need to think about how long we're going to actually treat a myopic child and even potentially managing progression even into myopia. So I thank you for your attention. It's been a pleasure to talk to so many friends around the world this morning for me. I know it's in the evening in Bangladesh and Pakistan and that part of the world. I'm easy to find, bullers2020@gmail, or bullers2020.com is my website. I'm happy to share a PDF of my presentation if you would like, but I would encourage you to seek out some literature on my website and continue in your education. So I'll pass you back to the organizers now and stop sharing my screen. There we go. And again, there's the QR code if you would like that. Iqra, back to you.
Yeah, thank you very much, Professor Mark Bullimore, for that exceptional session. Thank you so much. So now we will move into our discussion segment led by Dr. Angelia Perez, who is done PhD, MS, Fellow American Academy of Optometry, and Program Director at the University of Florida, USA, and Chairman of International Academy of Vision Science. So we are delighted to have you with us today, Dr. Perez. So after that, we will be having a Q&A session. So you guys can drop your questions in the comment box for Dr. Mark Bullimore, Dr. Maryam Jabbar, or Dr. Perez. So thank you so much.
Thank you so
Dr.
much
Perez,
for that.
are you there? Yeah, thank you.
Yes, thank you. Thank you so much for that introduction and that information. I want to thank our presenters today. They have been just absolutely amazing. This is wonderful information, and I am so grateful to have you all today with us. If you have any questions for either of our presenters, please put them in the chat box, and we'll be happy to pass these questions along if you have anything that you'd like to talk to our speakers about. It looks like we don't have any questions so far. A lot of good comments. Thank you very much. Insightful session. Perfect as always. Great information by both speakers are some of the comments that are being made right now, and we really appreciate that. Thank you.
Can I ask a question just for sort of my information?
Absolutely.
In terms of practicing in Pakistan and Bangladesh, what do you have access to do? What products do you have access to? And what does your scope of practice as an optometrist, for example, allow you to do? So I don't know who wants to answer that. I'm just curious.
Dr. Maryam Jabbar, ma'am. Dr. Iqra.
Yes, doctor.
Dr. Maryam Jabbar, ma'am.
I would like
Dr.
to
Maryam.
answer. Yes, I would like to answer. First of all, Professor Bullimore, it's great to have you here. Secondly, I would like to give an overview related to myopia control strategies in Pakistan. Actually, currently what we are doing, the Zeiss lenses are used for the myopia control in the major cities of Pakistan, Islamabad and Lahore, and initially in Faisalabad as well. So myopia control strategies including the Zeiss lenses, but unfortunately, exactly right now, we don't have any orthokeratology lenses for the myopia control because of the first thing is the budget proceeding financial concern, and second is the proceeding with the main proceedings. So initially, just what we have exactly right now related to myopia control, that is basically Zeiss lenses, and furthermore dual lenses proceeding in certain clinics. Furthermore, the thing that you asked about scope of optometry, what optometrists can do in Pakistan. Optometrists proceeding as primary eye care providers, proceeding from initially doing refraction as well as diagnostic optometry, including doing the OCT, B scan, biometry. That's proceeding with the diagnostic optometry. Moreover, in some clinic, we proceed being an optometrist as a low vision practitioner, as well as in different regions. We have ICL fellows that proceed with the contact lens proceedings. So if we sum up in our proceeding, we can proceed with the refraction and diagnostic optometry, as well as for the contact lens and low vision specialist. Initially, it's starting from the minor proceeding with the refraction, and later on till contact lens proceeding and low vision specialty. These are the few junks that optometrists can proceed in Pakistan.
Thank you.
Yes, so the question is, what strategies can be used to raise awareness about the importance of evidence-based interventions for all young myopes? Would you have an answer for us, Dr. Bullimore?
I think it involves everybody, obviously, as practitioners. Talking with individual patients, we have a role to play there. Basically, talking with the parents of young myopes, talking with the parents of children who are at risk of becoming myopic. And so starting early. Obviously, from a public health perspective, we have various organizations who try and get the word out. One thing that we'll also be seeing in the US, I'm sure, is some direct to consumer advertising from EssilorLuxottica with the FDA approval of their Stellus lens. So to be cliched, it does take a village, but we all need to play our part. And obviously, academic institutions like those in Faisalabad, where Maryam and others are from, also have an important role to play.
Thank you for that answer. I have a question for both of our speakers. Dr. Bullimore, you could begin answering, and then Maryam, I'd like for you to also give some input on what is your next research projects. What is the next thing that you'll be working on?
So what I was saying was that I don't see patients and I don't conduct hands-on research. So I don't have any things that are ongoing, but I can tell you some of the projects I'm working on with clients. So I'm working on 2 research papers on the safety of contact lenses in children. One is systematic review and meta-analysis, and the other is a review of a large number of clinical trials conducted by the company, 11 clinical trials over the last 20 years or so that really point to the safety of soft contact lenses in children. I'm working on other projects with my collaborator, Dr. Branham. We're looking at different targets for myopia control. So how reasonable is it, for example, for a myopic child to achieve emmetropic eye growth when they're being treated with orthokeratology or something else? And to give you the main finding, it very much depends on the age and the race of the child. So say in an older white child in Europe, it's relatively easy to achieve emmetropic eye growth with a good intervention. For a young Chinese child, say a 7-year-old Chinese child, it's very difficult to achieve that goal because their eyes are elongating so quickly to begin with. So those are some of the things that are ongoing. I have a number of other articles that are under review, but that'll give you a little taste of what my life is like at the moment.
Fantastic. Thank you for that. And Dr. Maryam, could you tell us what your next projects will be?
We are actually proceeding right now with the, as per World Council of Optometry Myopia Navigator, we main focus on first pillar, that basically the mitigation. We proceeding with the school screening, as unfortunately many students are living with myopia. They don't know they have myopia, their parents don't know. So we main focus exactly right nowadays, we proceed with school screenings, and initial phase we proceed with the 6 schools, then we proceed with the 8 in second phase we proceed with 8 school screenings, and in third phase we hope for the best, we proceed with up to the 15 schools for the main focusing as per myopia navigator mitigation. Mitigation is basically what we can do proceeding with, as in we are living in the digitalization era, more screen work, less outdoor activities. These are the factors that are the modifiable risk factors. So we are currently main focus to proceed with the mitigation of myopia. So currently we are doing with school screenings to mitigate prior to proceeding with the high or progression or proceeding for the consequences of myopia. So currently now we proceed with the mitigation of myopia to control or to aware the parents about the avoidable, because myopia is leading a cause of avoidable blindness. So our main concern is about to provide the clarity to those who don't know they have myopia. So we main focus is nowadays about school screening and the child at their younger age to mitigate them at the initial. So we are proceeding with the preventable strategies of in concern of optometry and the public health.
Okay, thank you for that. I really appreciate the information. We also have another question in the chat. What pharmacological therapy is used to slow the progression of myopia?
I'll have first stab at that. Atropine is the main pharmacological option that's used. There have indeed been over 20 randomized clinical trials of 0.01% atropine, and we know from those that it's effective, but I would say modestly effective. Atropine is much more effective in higher concentrations, say 0.025 and 0.05. The challenge remains with atropine whether you can get the drops in on a regular basis. So there are challenges for any parent to do the bedtime routine, and adding atropine drops to that can be challenging. Now, there are other ongoing evaluations of other therapies around the world. So there are drugs that have a different mechanism of action. So serotonergic drugs are being evaluated. One of my clients has been looking at nutraceuticals, so not pharmaceuticals as such, but looking at soft contact lenses that release tyrosine, which is important in the dopamine cascade. So there's a lot of ongoing work in a range of areas, and of course there's many other things probably going on in labs around the world and in companies behind the black curtain that we don't know about right now. So atropine at the moment is our primary option, but I expect that to change in the next 5 to 10 years.
Fantastic. Thank you, Dr. Bullimore, for that answer. We really appreciate the time that you've given us today. It's been so valuable. The information has been so very valuable. Dr. Salam, I'm going to turn it back over to you now. Iqra?
Dr. Iqra Salam.
Yes, I'm here. Thank you so much to all of our speakers for your valuable contributions, and thank you so much for your detailed answers. Moreover, that I would like to inform to all of the participants that Dr. Gazi Reaz Rahman, he wasn't able to join us today because of some issues. And moreover, that I humbly request a special prayer for Dr. Abdullah Al Mamoon, who is the low vision and contact lens specialist at Bangladesh Chittagong Eye Infirmary and Training Complex. His newborn baby is basically on life support in critical condition. So Dr. Mamoon was scheduled to speak with us today, but due to this this situation, he wasn't able to join us. So please keep his baby in your sincere prayers. May Allah grant his child a complete and swift recovery. So thank you everybody for your patience. So now we are reached to the end of our today's session, which was very insightful and impactful webinar. So on behalf of the International Academy of the Vision Science, I extend my deepest gratitude to all our honorable speakers for sharing their expertise with us, and our participants for joining us from around the world, and moreover that our collaborating partners and media teams for their constant support. Thank you so much, everybody. So, certificates will be issued shortly, and details of our next upcoming event will be announced on our official platforms. So, thank you once again for being a part of this international academic gathering. And this is Dr. Iqra Salam signing off from here. So, stay connected and stay informed, and see you all on 25th of November 2025. Thank you. Dr. Shahadat, would you like to say something to the audience?
Thank you so much, Professor Dr. Mark Bullimore. Thank you, Dr. Maryam Jabbar. And thank you, Dr. Angela Paris. Thanks to Dr. Iqra Salam. Thank you so much for joining today, Professor Dr. Mark Bullimore. Okay, bye-bye. Today it's closed, finished. Bye-bye.
Okay, thank you everybody. Allah Hafiz. Goodbye. Thank you, Dr. Professor.